Good afternoon, everyone. Thank you for joining us. My name is Dr. Becky Siegel. I'm one of the pediatric rehabilitation physicians at Boston Children's. I am here with Dr. Northam, who's one of our neurosurgeons. And for about the next 30 minutes, we're going to be talking about cerebral palsy treatments and the role of rehab medicine and neurosurgery in the care of spasticity and dystonia. We think about treating tone in a lot of different ways, but today we're going to focus mainly on the neurosurgical options. So we hope this information is going to help you either as a patient or a parent just to understand some of the options that are available at Boston Children's and hopefully answer some of your questions. There is a question and answer tab at the bottom of your Zoom. You guys are more than welcome to use that to ask questions throughout, and then hopefully we'll get to some of those questions at the end of the session after we're done talking. So pediatric rehab medicine physicians are medical doctors who focus on day-to-day functioning. We have a lot of different names. You might call us here PM&R doctors or rehab medicine doctors or physiatrists, but we really help think about medical treatment, therapy, equipment, bracing, any quality of life adaptations for kids and adolescents with any medical condition, including cerebral palsy, that might include day-to-day functioning. So there are actually only about 350 to 400 pediatric rehab medicine physicians in the country. And so there really aren't that many of us. So maybe you've never seen a rehab doctor, or maybe you do have one, but we can be helpful in a lot of different ways. And one of the ways that we're helpful is talking and helping with the non-surgical tone management. So that we kind of do all these things at the same time. One of them is stretching and therapy and bracing. Another one is thinking about medications that we can give by mouth to help spasticity. And then another one are targeted or botulism, Botox, and phenol injections with intensive therapy following. But today we're going to focus a little bit more just on the neurosurgical options. And I'm going to have Dr. Northam talk about that.
All right. Well, very nice to see everyone this afternoon. As Dr. Siegel mentioned, my name is Wes Northam, one of the pediatric neurosurgeons here at the Children's Hospital. And I'm lucky that I get to work with Dr. Siegel regularly. We're part of a big group of providers for patients with cerebral palsy. And we have a very team-oriented approach, which is why we're both here today to talk about this. We're really looking forward to answering some questions in a little bit, but I do want to talk about our role for surgery in patients with cerebral palsy. So, we were just talking about some of the non-surgical treatments with Dr. Siegel, and those are very, very important. However, sometimes they are not enough for some patients. And despite our best conservative treatments, like oral medications, physical therapy, and injections, sometimes the tone is not adequately controlled, and it can interfere with walking, sitting comfortably, dressing, even bathing. And not only can it be so hard for those patients, but also, of course, for family members and caretakers as well, to deal with patients that have that degree of tone or tightness. Some patients actually are not able to tolerate their braces or assistive equipment. For instance, can have skin breakdown or pain and discomfort from the tone, and can have contractures. And as we like to say, the tone is where it really starts from the nerves causing the muscle tightness. This can make the tendons shortened, which can then cause problems with the bones. And so there's a cascade of problems that arise from this tone. We have a number of different ways to classify cerebral palsy. So Dr. Siegel, how would you think about different groups of patients with cerebral palsy?
That's a really great question. And so I kind of think about what is affected and how we define that. So are a patient's legs affected, but their arms aren't? We use the terminology diplegia for that. Or is one half of their body, so the left side or the right side, affected? We call that hemiplegia. And then are all four limbs affected, which we call quadriplegia. So you don't really have to have a true terminology to understand kind of what's affected. And so we kind of think about how patients function in order to help us make decisions. So it's important to think about, is a kid with cerebral palsy using a wheelchair that they push themselves, or do they use a wheelchair that they require assistance to push? Are they walking using braces and crutches, or do they use a walker or a gait trainer that gives a little bit more support at the trunk? So kind of knowing that functional level probably helps you in helping this multidisciplinary team that includes neurosurgery, rehab medicine, physical therapy, orthopedics, and neurology, all to kind of make the best decision for a family and their patient about what option would work best for them.
So I think that's a really important point that you just mentioned in terms of kind of a customized solution that works best for a given patient and their family, because it's not a one-size-fits-all approach. And I think that's one of the themes that we try to keep in mind when we see patients. And so keeping that in mind, let's talk about some of the options that we offer as neurosurgeons for cerebral palsy here. One of those is called a baclofen pump, which some people may be more or less familiar with. And that essentially is, I like to say, a metal hockey puck looking device. You can see some information here about that. It goes under the skin, usually underneath the skin of the belly between the ribs and the hip. And then we also run a small tube under the skin that goes into the back and up into the nerve sac. It provides medication from the pump up into the nerve sac to help relax those nerves that are under so much abnormal tone. And so that is one option. We like to talk about the different classifications of cerebral palsy because the options that we have depend on what the functional status and the needs are for each patient. The advantage of the baclofen pump is that it's titratable or adjustable, so that we can wirelessly through the skin adjust how much medication is being delivered to achieve the right level of control for a patient. The disadvantage is that it's a pretty big device, and some patients don't have enough space in their body to accommodate it. It's also, a big piece of metal with plastic tubing associated with it, and whenever we implant hardware, there's risk of infection, or like any machine or device, there's risk of malfunction. We also go through a long process to make sure that patients are ready for a baclofen pump, because their body will become dependent on the baclofen medication when it's infusing, and it can be very helpful, but it also needs to be, regulated and monitored closely so that we know that it's being refilled at the right intervals to make sure that the patient always has the right amount of medication. That is one of our common options for treating tone, but we do have other options, and one of them in particular is called a selective dorsal rhizotomy. You can see that on this slide, abbreviated SDR. This is a surgery that's very helpful for patients who are walking with or without assistance and need to be able to walk better. And our goal is to decrease some of that extra tone, especially in the legs, to allow for that walking to improve. This is why, Dr. Siegel was mentioning all those different categories and types of cerebral palsy. This is a surgery for patients who have what we call spastic diplegia, or tightness mostly in the legs rather than the arms and legs in particular. And so we think that if patients are strong enough to tolerate this surgery, it can actually help walking considerably and comfort as well. We can talk a little bit more about the nuts and bolts of surgery as well, but this involves making an incision in the lower back and actually operating on the nerves themselves under a microscope to find the bad actors that are contributing most to that tone in the legs and hips, and making small cuts so that we decrease permanently the amount of tone that goes down into the legs and hips. And that can be a really big improvement for some patients and their families. And the third category that I want to mention is something that we are excited about as an option for patients. And it's called a combined rhizotomy. And this can be confusing because it sounds like the option we just talked about, an SDR, but it's actually different. And it's for a different group of patients. And so the combined rhizotomy is offered much more commonly to patients that historically would get, for instance, a baclofen pump, who have tone that is so severe that they are unable to walk well or walk at all. And so it is designed to not to make patients walk better, but rather to increase quality of life by simply loosening the legs and hips. It also does improve tone in the arms, but not to the same degree as it does in the legs. And this can be a powerful option for some patients, especially those who have had trouble with baclofen pumps or are not candidates for a baclofen pump or simply don't want a baclofen pump. And so we think that it's not so much that one of these things is better than the others, but rather that they both are better for certain situations and certain patients. And so we like to be able to offer multiple options depending on what is going to be best for a given patient or their family. And historically, we really just had the two surgical options. One was a selective dorsal rhizotomy if patients were walking and had tone mostly in their legs, or if it wasn't that, or patients just had really bad tone in the arms and legs or weren't able to walk, then there was no other option besides a baclofen pump. And so we're happy to be able to provide more than just that going into the future, given that we know we can really reduce the amount of tone with combined rhizotomy in patients who historically would have only had baclofen pump as an option.
Thanks, Dr. Northam. I think that's really helpful. So overarching, just to make sure that I totally understood what you were saying and kind of to help everybody else who's watching this, we think about SDR for kids who their legs are just affected. And what age do you typically think about that?
Yeah, that's a great question. I think that when we're talking about selective dorsal rhizotomy, as you mentioned, that is for kids who are walking either with or without assistance. We're trying to make them walk better. And we generally like to offer that surgery at a younger age range, especially between about 3 years and 9 years of age. If we can even do the surgery before 7 years of age, we think that that's an extra sort of benefit because there's still so much motor learning left in the brain at that point, which is to say that the child is not yet fully learned how to walk. And so they get even more benefit from correcting that spasticity earlier on. But we do see benefits even going into adulthood in some cases, or certainly teenage years. But we really like the opportunity to be able to offer it at a younger age for that range, about 3 to 9 years old.
Yeah, one of the things from a rehab perspective too is the ability to really participate in an extensive rehab program after an SDR or a selective dorsal rhizotomy. Some kids who get that procedure will recommend inpatient rehab, which is decided actually when they're in the hospital after they've gotten the procedure. And some kids benefit from that intensive therapy, but if they can't participate in therapy, it makes it harder to do that. So that's another kind of sweet spot age thing that we talk about. And some 3-year-olds are really good at participating and some 7-year-olds aren't. And it kind of depends on the patient and helps us make our decision. So, and then for kids who aren't walking, we're thinking more about the baclofen pump or the combined rhizotomy based on kind of their caregiver burden and what the family kind of wants. Is that correct?
That's correct. It can be very individual based on what is going to be right for that patient, that family. We definitely want to offer both options if they are good options for that patient. In other words, the rhizotomy or the baclofen pump, and to really talk through, the risks and benefits of both of those to see what would fit the best. They're both big undertakings for a family to go through, and so we think that they deserve a lot of discussion, and we certainly want to make sure we give you all the options.
Yeah, and so for SDRs, we are thinking about that, prime age that we see kind of the most benefits, but for baclofen pumps and combined rhizotomies, these are things that can be really done at any age, and it's not as specific in terms of timing, correct?
That's right. And there are some important differences there also, not just the age range, but also the therapy after the fact. So, when we do selective dorsal rhizotomy for patients who are walking, we always try to follow that with an intensive inpatient rehabilitation in order to get the most out of that surgery, because we always like to say the SDR is really just half of the equation. The other half is the therapy work that the kids do to get strong afterwards. And that's very different, between an SDR and a baclofen pump or a combined rhizotomy, because the baclofen pump and the combined rhizotomy are designed to increase comfort more than anything, not necessarily to make walking better.
Yeah, and sometimes we can do a baclofen pump to make walking better because it is titratable, but it's a little bit different in that you don't really have to retrain walking, which after an SDR, you really have to learn how to walk again because the nerves have been cut and there's a disruption in that connection between the brain and the body. So I think that actually starts us off at the first question that actually came in ahead of time, which was, are there specific protocols you're following after dorsal rhizotomy or combined in terms of physical or occupational therapy? So that intensive therapy after a selective dorsal rhizotomy is something that we're more focused on, whereas typically kids after a combined rhizotomy can go back to kind of their baseline therapy protocol that they had prior to surgery.
That's right. We think that it's very important to have not only a protocol in place for optimization of the surgery after the fact, which is the rehab, but also for right after surgery and in the operating room. And that's something we've spent several years developing, and have actually published in the scientific literature as well, to show how beneficial it is to have a protocol where we maximize the amount of pain control by using an epidural pain catheter. And that way we have patients who don't require as much opioid medication during the hospital. And we think that leads to less narcotic medication use, more comfort, and getting up and going faster after surgery.
This is another great question, is if a kid has an SDR when they're younger, do they have to do it again?
That's also a really good question. Luckily, we do have good data in our scientific literature about this. We now have over 30 years of data to show us that the effects from SDR in treating spasticity are permanent, which is to say that over that 30-year time period, we don't see any decrease in the control over the spasticity. We don't expect it to come back. The only little star I would put, or disclaimer to put, is that is when we are very careful about selecting the right patients for surgery, because certain patients can have tone that is unlike our normal population of cerebral palsy. For instance, for certain genetic conditions where the tone changes or worsens over time, that can sometimes make the effects of SDR change over time too. And so we're always careful to say that when we're selecting the right patients for the surgery, and to say that, this is what we expect based on our 30 years of data. But if you're in a different patient group, we might not be able to make that same exact prediction. So it is different for different groups of patients, but our most common group of patients with cerebral palsy, we do not expect to have to require another SDR procedure. We consider that to be permanent.
Yeah, I think another good question that's come in is, if somebody has a baclofen pump, could they actually get a combined rhizotomy later? And that's something that we talk about a lot in our clinic, is that You doesn't mean one or the other. You can get a baclofen pump and then get a combined rhizotomy, or you can have a combined rhizotomy and then continue to have spasticity and choose to get a baclofen pump. So this is something that's not an either or, and it's definitely something that we think about and talk about with patients, that we could actually get both at different stages in life depending on what's going on.
That's a great point. Yeah, it's not a contraindication to have one and then not be able to have the other. So one example of that would be a patient who has a baclofen pump but doesn't get adequate response from it. We think the pump is working, but just not doing its job in terms of the medicine for that patient. We can actually remove that pump and do a rhizotomy if needed. That's certainly something we do occasionally. The reverse is also true, as you mentioned. If for some reason a patient needed a baclofen pump and already has had a rhizotomy, that is okay too, and it's certainly something that we can do. So that's an important thing to keep in mind when making a decision about surgery too.
Yeah, one of the other questions that has come in a lot, there are a lot of questions about dystonia, and I think this is something that we talk a lot about. And one of the reasons that when we do these visits, we have this amazing multidisciplinary group looking and helping us make these decisions about what the best option is because, spasticity and dystonia are a little bit different. And so one of the questions that we have is, do you see a reduction in dystonia with the combined rhizotomies?
Yeah, very interesting. So short answer, yes. The advantage of the combined rhizotomy, the reason we call it combined is because it combines the effects of the dorsal nerve roots that help with spasticity and part of the ventral nerve roots that help with dystonia. So it actually can help address spasticity and dystonia, but again, it's mostly in the hips and legs. It does, for many patients, help with the arms as well. But to give you an example, some patients with dystonia have, very severe, for instance, twisting of the neck and head into certain postures. It's not necessarily designed to help that. Although sometimes what we've seen is when you decrease some of the abnormal tone going to the hips and legs, especially when it's problematic, it can decrease some of the burden of dystonia in other parts of the body just because we're decreasing the amount of discomfort that's there. But that's a really important point because doing a regular SDR is not necessarily helpful for a lot of patients with spastic quadriplegia or mixed quadriplegia and dystonia. But the combined rhizotomy, as you mentioned, can actually be used to treat tone that comes in the form of dystonia as well.
Right. So if a kid had primary dystonia, mostly in the legs, our decision making would be a little bit different because an SDR doesn't really help that dystonia. You really need the combined feature, but we don't do a combined if a kid is ambulatory or walking because it's going to decrease their ability to get around on their own. So the patients who have dystonia are a little bit different, and we think about them a little bit differently than we do for other kids. One of the we have a couple more questions. Another question that came in is, in order to do a baclofen pump, do you have to max out oral medications first? And the answer is no. And so there are a lot of side effects or a lot of other reasons why we wouldn't max out enteral medications such as baclofen or Valium. There could be side effects, so we can't go any higher. It could be for kids who have a lot of low tone in their trunk or their neck. We don't want to increase the dose because their tone is really specific to the legs. So it's not necessarily exclusive. It's not a criteria for us to consider a baclofen pump or a surgery in order to max out those medications. Another question is, do all kids with CP get surgical management?
Yeah, this is a great question, and it's an example of why our group, when we see patients in our multidisciplinary group, we have so many different specialists amongst us, and not all of us are surgeons, and that's because we always start with non-surgical options, and even when we do surgery, the non-surgical options are still crucial to be going concurrently to maximize patients' care. So many patients with CP do not require surgery, but do require the services of someone like Dr. Siegel, who's an expert in medications and non-surgical treatments.
Great, thanks so much. So one other question is, would these treatments apply to other pediatric genetic brain diseases that are not cerebral palsy? And how do these treatments for CP cross into the newly identified rare genetic diseases that in the past did kind of fall into the CP category? And this is a question that if you talk to anybody who cares for patients with CP can probably talk to you about for many hours. And we go to conferences and we talk about this at conferences a lot because it's a really hot topic and a question it's a really great question and something I don't know if we really have a 100% answer to. Anything that causes spasticity can be treated with some of these modalities, right? One of the things that we think about in terms of some of these other genetic conditions is the condition progressive? So is it going to get worse with time? And so cerebral palsy is a one-time injury to the brain that leads to spasticity or a change in function. And so for some of these other genetic conditions that are progressive and get worse, would a rhizotomy be the right answer, right? And I think that it's hard to know since it's hard to know what the progression of the disease is. There are definitely patients who have spinal cord injuries who have severe spasticity who get baclofen pumps, and we've thought about getting rhizotomies for as well. So I think it's definitely can be applied to other populations, not just the CP population, but that's definitely something that takes a little bit more thought for our multidisciplinary team to kind of think about, because we don't want to do something that we don't think is going to help long term, because there are risks with everything that we do.
Yeah, and just to piggyback on that too, that's why one, of our important members of our CP team is actually a genetics expert. And so while patients are in seeing us, if we think, hey, this patient might really benefit from some advanced genetic testing, he can literally be there during the same visit and can bring his team in to help coordinate that. So it's a very good question. It's a very important question that's becoming more and more relevant the more we learn about genetics of CP and other diseases that can create spasticity and dystonia.
Yeah, these are all really great questions. We unfortunately we don't have time to answer all of them, but either myself or one of my partners, rehab physicians, or Dr. Northam or one of his partners in neurosurgery, even our complex care pediatricians and our neurologists and orthopedic docs that work in our CP center would always be happy to help and answer more questions. Obviously, this is a very tailored approach, and this is not something that we're going to say every single kid who has this diagnosis needs this treatment, right? We really try to be tailored to every specific patient and their family and what their needs are. So if you have any questions, you're always welcome to reach out to the CP Center at 617-355-5870. And we're also going to be sending out a recording for this in the next few days if you would like to watch it again. Any final thoughts, Dr. Northam?
I think you absolutely, captured all my sentiments there too. I would just say that, we are really happy that we're able to offer multiple different kinds of options for patients and their families. I think the idea that the baclofen pump isn't necessarily the only option anymore for patients with advanced, really problematic tone is an important one. And it's something that we really like to keep in mind when we're seeing patients and families. And we look forward to being able to answer more questions, and thanks for having us.
Have a great rest of your day. Thank you.